All right, welcome everybody. Thank you so much for joining us. I am super honored and happy to be able to invite my friend Michele, Dr. Michele Ricard. I'm going to tell you a little bit about her, and then we're going to get chatting with her about denying the human element. Dr. Michele Ricard is a specialist in geriatric and internal medicine. She is a certified medical director serving patients living in skilled nursing and rehab facilities. Throughout most of her career, Dr. Ricard was a clinical instructor for medical students until retirement about 2 years ago. She frequently lectures, sharing her years and wealth of knowledge to inspire and educate medical professionals. And she started a group, founded the group Elder Community Collaborative, which is centralized in the Marlboro-Hudson area. And we work to better the senior community and services and educate the seniors of those communities. However, she first initiated this group, gosh, I want to say 20 years ago, and I've been a part of it for a lot of those years, initially to improve the communications and outcomes for patients who are transitioning from nursing home to home or hospital to nursing home. And so Michele, why are we talking about denying the human element, and what does that mean for you? And why do you feel that you're so passionate about this topic?
Well, because being a patient isn't just about receiving the technology and the medications that a doctor can prescribe for them. It's about being the person to whom these things are being done. And as a physician, over the many years, I've always enjoyed learning about what makes that patient, I'll call them patient in front of me, what makes them a person. It isn't just about how their heart is ticking or how their lungs are working or, you know, a skin problem or something like that. It's about them, how they grew up, what their family is like, what their hobbies are like. And therefore, I get to know them as a person. And when I am treating them, it's that tapping into who they are as a person that helps them heal, because it's not, they're healing themselves. I am helping with whatever medical technology or drugs or whatever it is that are needed. But more than 50% of the person healing is their own effort, their own spirit, their own drive, their own motivation. And particularly for elderly and demented patients, that drive and motivation comes from seeing, feeling, touching their loved ones, their family. And these people, 70, 80, 90 years old, they've spent those 70, 80, or 90 years old being with family, either their own family growing up, and then their family that they've had when they've got married and had children, and their connections that way. And to deny them this because of the virus is just denying the fact that they are human beings and need this interaction. And that's what got me so upset with the social distancing and the fact that, well, the social distancing, and also the fact that learning that hospitals will not allow visitors in, whether you're having, some emergency surgery or whether you've got COVID, no matter, unless you are dying, in which case apparently the team makes a decision about whether a loved one can come in. But that's not what loved ones are supposed to be doing with someone that they love.
Absolutely. I think that you brought up a great point about the human touch, the human element, touch and hearing, all that sensory, especially for people living with dementia, it is really negatively impacting their will to live and their drive to get better. And I think I mentioned to you, I think I'd need to be arrested if one of my loved ones was in the hospital and I couldn't go see them, because it's just for the feelings of the caregiver to be able to make that decision that I want to see mom, I want to see dad. And I think, we had a call earlier today, Michele, where someone working for hospice was talking about how there's such a limited amount of resources right now. The hospitals are overtaxed, the nursing homes are overtaxed, that it's tough to even get hospice in. And when they come in, it's at the last and final moments when, unfortunately, is too late for a lot of these people.
Right, exactly. But I think what's needed, even, in conjunction with the hospice for dying patients, the elderly person needs this ongoing family contact. And, touching fingers on either side of a glass pane is just, I mean, it's innovative. iPads, FaceTime, all these things that doing the Zooming that we're doing now, it's all very innovative. And for those of us that know that we're going to probably survive, this COVID thing, and we've got years ahead of us, we can put up with, a few months or a few weeks of this innovative, interesting stuff. But for people who don't know, who are in those last months or last year of their life, or whatever it is, they don't know how long they've got. You're denying them living, and we're denying them proper living by putting these barriers up. And the young people think being intimate is texting each other on their iPhone. Guess what? It's not. And although it is very nice, and I applaud their innovations in bringing iPhones and iPads into these people in the hospital and showing them family and family photos, I can tell you it is not the same. And it could almost be more distressing to somebody to see. I mean, a demented person can look at a TV and think, and doesn't understand that it's a TV, or doesn't understand that it's a face, because they're not seeing the real person. I don't know whether it's the three-dimensional component or whatever it is, but they just don't get a flat screen. They need that three-dimensional person to be there. And it's just not the same.
In a lot of communities too, where they have memory care, what is the challenges that they're faced due to this social isolation, trying to keep them not engaged, and that is a treatment. We know that is the best treatment for people living with dementia, is have them socially connecting, human touch. And unfortunately, we're disconnecting people. So I feel like, they're not even, these poor care workers in these communities, forced to wear their PPE. Picture someone living with dementia who can only read your face, who only can pick up on your emotions and understand what you're saying when you are face to face with that person. And now they've got the barrier of the mask, the muffled voice. They've got the gloves instead of the human touch. And, the fact that caring for someone with dementia in particularly is all about touch.
Mm-hmm.
So I'm very, very concerned about these people who are forced to be eliminated of having the human element.
Right. And I think there should be more of a choice, that if you choose to to expose yourself or to expose them to the possibilities, it becomes, quality or quantity, which is sort of, again, getting back to your end of life choices. Do you want to live your life, in a bubble, but potentially live a little longer? Because we don't know that all these elderly people that are being exposed, they're not all going to die from it. Some are, yes, but not all of them.
Right.
And so the family and the person needs to be able to make that choice. Someone may know they've only got 6 months to live and they don't want to spend 2 months in isolation. They want to live. And if those 6 months become 2 months because they get COVID, at least they will have lived. and you know, whatever that person's definition of living. And I go back to that Atul Gawande book, you know, Being Mortal. What does it mean to you to live? What is your life worth, if you will? And I think we have to respect people's wishes in that, and not just deny everybody human touch and human visitation because, well, you know, society needs this, or the herd needs this, or whatever. As a medical director, I've had to wear two hats. I've had to wear the personal hat of being a doctor for, you know, these patients, and I've had to then put on my medical director hat when we run into a situation where we have to deal with a flu outbreak in the nursing home, or a GI, gastrointestinal infection or something. And I've had to make decisions with the director of nurses and the administrator on, you know, how to organize patients within that nursing home. So I in a small scale, I understand about looking at, you know, the big picture. But I was also the physician for these patients, so I knew them personally, and I knew that, you know, Mrs. Smith was going to handle it a little differently from Mr. Jones, and that we had to do something a little different from them. You can't just blanket everyone with the same thing, and that is missing in what's being put on us right now.
You know, I watched a news story this morning. I'm trying to stay away from the news as much as possible, but I did watch it about the prison system and what's happening with them inside these prisons, where there's no ability to socially distance themselves. And one person was on talking about civil rights, that this goes down to basically a civil rights issue. And, you know, it brings up a thought in my mind about all the vaccinations that we require our children to have, and is it parent choice, or is it mandated by our government to have people vaccinated because we're protecting other people? So there's arguments for both sides, and I'm sure that there are people that would, you know, disagree that you know, we don't want to expose other people, we don't want to put more pressure on the hospital or the communities because they want to protect their other residents. But then I think of the family member that can put on the PPE and go in and actually create that bond and that connection, but because the administration decided. So I think this is just opening up a huge discussion that needs to be brought into the medical world, because are we going to deny this ongoing in healthcare? You know, they're talking about another whole wave of the COVID coming through.
I think it's going to continue to wave until the herd has immunity, until we as a society have enough immunity that there's nobody's just spread it to.
Right.
And either we get that because we've contracted and developed immunity ourselves, or the vaccine, you know, comes around. But again, just another personal story here about only the family knows the resident, knows the person who's in the nursing home or the hospital. My mother had dementia, and she was in Australia. I was visiting, and she was within the last year of her life at that point. And she didn't really know who I was, and I was decided to start rambling, talking to her. And I thought, well, if anything, she's going to remember things from way back in the past. So I tried to go way back when, as Mum and Dad would drive us down from our place where we lived in Birmingham down to Swanage, a seaside resort place. And as we drove down, one of the things that they would, you know, always have the kids do something to keep us interested in the drive, you know. And one of the things we saw were these white horses on the cliffs as you're coming down a certain part of England. And it was always, you know, who's going to see the white horse first? So I was telling her this story. And when I said, remember the white horse, who's going to see the white horse first? She made direct eye contact with me. She beamed from ear to ear and said, yes, yes. So I knew that through that Swiss cheese of a poor, you know, neurons that she had left going on in the brain there, that I'd made a connection. Now, who else would know that? You know what I mean? There would be nobody else but maybe my brother and I, that would know that story and be able to make that connection. And that's a verbal connection, but it's still intimate details that nursing staff and that wouldn't necessarily know. And that's why, again, having that family contact to be able to connect, particularly with demented people, is just so important.
And not only that, too, the ability to advocate.
Mm-hmm.
When people go in and visit their loved one in any type of residential community or institution, they're able to say, my mom's not getting this, my mom's not getting that, I need this changed, I need this, in advocating for their loved one. Now, they're just total dependence on the healthcare professional. And you're absolutely right. As much as they try, as much as they care and are compassionate, they don't have those tidbits to
Right.
create those moments, those positive moments in someone's end of
Right.
life.
Right. And they're just little moments, they're little windows, but it's just, it's just a good thing for the patient to have those moments. But yes, I mean, the nursing home staff that I've worked with are very compassionate, caring people. They really are. A lot of them have, grandparents, parents of their own. So they treat them like that's, who they are, but it's not family. Apparently though, nursing homes are given discretionary what's the word, rules. They can use their own discretion about letting people in under certain circumstances, wearing proper, they're tested for temperature and they wear the protective equipment. But it's not, as the hospital is nothing, but the nursing homes have discretionary power to let families in under special circumstances, I heard. So it's not completely out.
So I would guess that the family can advocate to go in in case by case situations,
Right.
And my concern is that when we see that increasing issue of increasing behavioral and psychological symptoms, what do the facilities do? I mean, they're not going to be sending them to the hospital. They're not going to be, the geriatric treatment units. And I know of a woman that her mother fell in memory care. The EMTs wanted her to go to the hospital, and the daughter refused her transport, said she's not going. So now I'm like, wait a minute. Although going to the hospital is a negative thing, will her pain be managed? Is she getting the proper care? So there's just a ripple effect of these negative consequences that can happen. And I thought having you come on and talk about this was something I had never even thought of, other than hearing stories about people not having their families with them as they're in ICU. But I would like to open this up to the audience, and if you folks could use your chat window to type in any questions for Dr. Ricard, now would be the time to do that, and I will field any questions, so please feel free to do so. And hopefully we'll get some questions, Michele, so that we can continue the conversation. And also if you have an opinion, because we all have our own opinions on the topic, so would definitely welcome anybody's opinion into the discussion.
Right. Yeah, apparently in the hospital setting, I did reach out to a hospital to get, to know the facts about what's happening there. And if someone is dying, apparently the team looking after them makes the decision whether a loved one can go and visit with them. But again, this is apparently, it's a case-by-case thing, and the team can make a decision. And I guess there were recently 2 people that did die alone in the hospital without family. I guess the team must have made a decision that they didn't want the family in. But again, that is just very, very sad. I mean, you go for surgery, you expect to say, well, I'll see you when you come out of rehab or something like that. But a person's dying. I mean, you can't say, well, next time you die, I'll be there.
Right,
I mean,
right.
it's one time only, and it's okay if there's actually, if someone dies unexpectedly, car accident, an airplane, or something bad like that. And we have to acknowledge the fact that, yes, we're not going to say goodbye to them because it's happened and we're not there. But if someone is known to be going through the dying process, then I think to deny family for that is unconscionable.
Right.
And I'll say that. I think it's unconscionable. And,
So I do have a question or a comment here from one of the attendees. So I am an ombudsman, and it has been so hard to see what is going on in nursing homes. I wish I could do more, but you cannot. So sad for everyone. That personal touch means so much. So people are
right.
seeing it, Michele.
Yes.
People are
Yes.
seeing it, feeling it. So this is
Right.
not just your what you're witnessing. I think it's something globally that is a big issue.
But I think it's like the emperor has no clothes. Somebody has to say that. Somebody has to say that we're denying these people this, and it's not right. It's not right. And no, not that we can let willy-nilly open the doors and have
Right.
people come in and out. We still have to show some care. However we couch that, however we put that, whatever policies we have. But we've got to realize that getting better and staying healthy as humans involves being with other humans that we know. That's who we are. We're not doing our own thing, all by ourselves. I mean, we're social people. So I think there needs to be more rumbling
Well,
about
yeah,
this.
because the way things change is from people's passion, right?
Right,
And people get passionate about things, and they
right.
start, they start talking about it. And really, I mean, my hope is that putting this interview on social media will allow people to talk about it. Just talk about it, and then having it roll up to leadership, where even as someone working as an ombudsman, they're there to help advocate and assure dignity and proper care and be that go-to person, and the ombudsman is seeing it. So
Mm-hmm, mm-hmm.
it's going to take time. It's going to take people to lessen their fears a little bit. We have healthcare workers that are COVID positive that are working.
Mm-hmm.
I mean, how much protection, how much of a bubble can we put these people in?
Mm-hmm.
I don't know. It's just so someone has commented, I
Oh,
fully agree that we need to figure out ways to get families significant but not essential caregivers in to see their loved ones. I am just struggling with how to safely make that work. Do you have any thoughts or ideas about how to advocate for visits while managing the risks at the same time?
well, certainly. I mean, there's several ways that you could do this. You could have a special room where visitors come in, so they're not walking through the whole facility. So we could have a room set aside for visitors to be with their loved ones. If it was good weather, then I'd say, put them outside and let them visit outside. As
Absolutely.
good weather comes, we have a really good day, then put people outside and let them visit outside. It probably is prudent to, at least with a temperature, to tell whether someone might have an infection or not. Um, but yeah, I think having a special room to visit and having that set aside, you know, and then it can be cleansed down between families or something like that, you know, some sort of a room that you could do that with.
And I
But
think it's hard, especially because the person that doesn't understand what's happening. So given the person living with dementia,
mm,
you know, you put the family there, you put anybody that they're close to, and they're not going to understand the need for distance. So this, you know, I could invite my neighbor over and say, hey, let's sit outside and sit 6 feet apart and have some
right,
social time.
right.
But that is a real hard thing to explain to a loved one who doesn't understand what's going on.
Well,
So,
I think that that begs the question about what is important to this demented person's
right,
life and to that family's life. And giving someone a hug, as long as you're not, you know, kissing them on the lips, direct, you know, mucous membrane contact, um, you're, yes, you could, you know, cough and speak and all that stuff, but what is going to be important for you and for that loved one's life that you want to remember? And is it that you hug them and you got close to them, but yes, they ended up getting the virus, and 10% of them, and it's a small percentage, but some of those will die. Is that something that you can live with, or would you say no? I don't want to give, you know, I don't want to griff grandma no matter what, so I'm going to stay 6 feet away and deal with that. And but
right,
that has to be an individual thing. And I think some young people, and again, or some people, I shouldn't say that. Maybe some people who are not in the nursing home field do not understand the the touch, feel, human side. You know, people who are in the hospital don't understand the nursing home environment. It's all about technology and getting this scan and that X-ray and blah 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 blah, and it's all about technology and lab tests. In the nursing home, we do use technology, but it's a lot about, you know, touching, feeling, helping, washing, bathing, and all that stuff. And there's people that don't understand what it's like to be in a nursing home. It's not just like being in your home, but you're with other people, not the family.
right,
It's totally different. And maybe people need to understand more about what a nursing home atmosphere is like. You know,
right,
we try to make it home within a home. You know, that we try to make it homey,
right.
but it isn't. But it isn't home. You know.
The person that it works as an ombudsman said they did allow with my nursing home to have people go out for fresh air on Easter because it was so nice that day and it did them a world of good and made them feel human. And my biggest thing when I had my caregiver series, I'm talking to caregivers and I'm like, get outside. You
Right.
know, I mean, these people need sun on their face. They need fresh air. They need, you know, to go outside for a while.
Mm-hmm.
And of course, you know, do they have the manpower right now to do that? Do they have a secured area where these people can go? But I think one of the things I've really pushed people to do is to go outside. And I think maybe you're right. Maybe we'll see more um, limits sort of lessened when people can get outside on a regular basis. I mean, the wind chill this morning was what, 17?
Yeah, it was pretty
Where
bad.
it's April 22nd. What is that?
Right.
So that's limiting people as well. But I hadn't thought about having a separate sort of family visitation room. But then I think, oh, the administrator's thinking, okay, so we have that room, family comes in, visits with that person. Now we have to quarantine them for 14 days because we don't know where those other people have been. I don't know. It's a panic sort of reactionary, like you said, without thinking about the human element.
Right.
So, well, first of all, Dr. Ricard, thank you so much. I do have one other comment. I feel like this is a bigger issue in that even those without dementia are being put in an increased risk of dementia as depression is increasing, as isolation is drastic right now. Also, currently, senior housing authorities have saran-wrapped benches, etc. What a great point, because, you know, in this country, we already had an epidemic of social isolation amongst our older adults, and we already have an overwhelming amount of older adults with untreated depression that can then lead to dementia-like symptoms. And so this, again, I think we're talking a ripple effect.
Mm.
You know, thoughts on that with the depression?
Definitely, yeah, depression can certainly mimic dementia. And when someone presents and the family says, we think so-and-so is demented, one of the things you have to do is rule out depression. So yes, when you're depressed, it can make it seem like, you know, that you have dementia, but it can be teased out. But yes, the social isolation can definitely lead to depression. And so again, foraging, you know, these new ways of interacting with people, but physical contact also is going to be important. But I think that's the problem with this. We're not thinking about the long-term human consequences of this.
No.
We're just about, well, we just got to get these numbers down, or, you know, what are the numbers today?
Flatten the curve, as they say, right?
Right. And you know, I mean, that's been important, so we didn't overwhelm the medical system. But I think we have to balance that and titrate that with, okay, now we've looked at that, now we've got to look at the human element. And what kind of human trouble are we going to end up with as a consequence? We may not have them die of COVID. We may have them dying of something else because we've created another set of problems.
It was interesting. I read something as well that looked at this whole crisis in different perspectives. One perspective being, you know, the perspective about a person that is now forced to be with their loved ones and their kids or whomever in a home, and they're enjoying and embracing this time, while someone who may be the victim of domestic violence is now stuck in the home with their abusive person. And unfortunately, I've seen all too often the person who is stuck in the home with their loved one with dementia 24/7, the caregiver burnout. This stuff
Right.
leads to abuse. It leads to neglect. And you're right. These are all things we're just not thinking about because they put on the back burner because of the medical perspective of keeping those numbers down.
Right. And to be honest with you, I'm not sure that the people who are thinking about all these measures, if they haven't been in contact with someone with dementia, if they're not part of that dementia field, dementia caregiver group, they don't know what we're talking about.
Exactly.
They have no concept of it. You know, it's like trying to talk to a geriatrician about pediatrics. It's like, you know, it's like a foreign language. And so they don't understand dementia. So I think there's some education that needs to be, you know, gone on with them so that they can understand when they make these rules and regs, what it does to different groups of people.
Right.
So I think, I mean, I think there's been a lot of education now through movies and other things about dementia, period. You know, we've had world leaders get dementia. We've had the movies on dementia. So the public is more now aware of dementia. Before it used to be just senility and we didn't want to talk about it very much. They were
And
just
you
getting
know what?
old.
Maybe physicians, because Governor Baker has that law in place he put into law last year, where all physicians, all nurses, acute care hospitals have to be educated on dementia. Maybe this will become a better, bigger discussion. So one of the persons, they're asking, what are the next steps with advocacy? Like, as a healthcare professional, an ombudsman, you know, home care, works in a community, works in a nursing home. What do you think they can do to positively bring this about as a bigger issue?
Well, I think we need to attract more public attention to the problem so that it's not just one ombudsman, one physician. We need to get the community understanding that there is a problem. And so that once we get some public dialogue going on, then the people that started the dialogue in the first place, you know, we can get together and then, you know, spearhead something, you know, going forward to higher levels or something. But I think there has to be a public understanding of the problem. So, like you said earlier on, you know, people maybe will see this interview and you know, have some thoughts about it and, you know, maybe get something going from this. But,
Maybe a collaborative, right?
maybe another collaborative, right?
That's right. Well, thank you, Michele. Thank you so much for joining us today for this interview. I really hope this does make people think and that this does make a difference. And I want to thank the audience for joining. This is going to be available, and I will be posting the link so that we can pass it on and hopefully get people to catch on with this. So any last words, Dr. Ricard?
Thank you, Tammy, for asking me to do this and encouraging me to do this rather than just, you know, having a conversation at the ECC and getting frustrated by myself. So thank you
wonderful.
very much.
Thank you so much, and you have a great rest of the day.
And you too. So